We're now going to begin our bedside rounds with Mrs. Alice Jones in room 310. Let's make sure to remember to talk to her and not about her, and stick to our time schedule. It should only take us about 10 minutes. If we need to go over anything else with Mrs. Jones, we can, of course, come back and see her later. Is there anything that we need to discuss before we go in to see her?
Yes, let's figure out what's going on with this anticoagulant. It appears Mrs. Jones was started on warfarin last night, and I'm wondering why. That's different from what we decided to do yesterday. What happened to our plan to start the apixaban? Maybe the resident on call didn't get the message about the change in plan?
Actually, I did not get the time to document in the electronic medical record that apixaban is in fact covered by Mrs. Jones's prescription drug benefit insurance plan. This was important since the medication is so expensive. The resident probably just assumed it wasn't covered and wanted to make sure the patient was started on an oral anticoagulant. We typically do this to transition patients off of IV heparin. My apologies for the oversight. I looked into the issue but didn't do the best job in closing the loop in communication.
Okay, I checked her renal function just now, and it's okay. So it is appropriate for her to start apixaban. I'll correct this order right now.
And I'll explain to Mrs. Jones why we're stopping the warfarin.
She will need to be started on 10 milligrams of apixaban by mouth twice daily for 7 days, and then 5 milligrams twice daily thereafter.
Can we start apixaban today, or does this delay her transfer?
No, since she received just 1 dose of warfarin, she can start on apixaban tonight, which will be 24 hours from her last dose of warfarin. There's no harm in her receiving warfarin for anticoagulation, but the apixaban will be more convenient for her when she goes home. As you know, it does not have to be monitored with frequent blood work.
I think we're all set. Let's go in.
Okay. Good morning, Mrs. Jones. As you probably remember, I'm Dr. Terry, and I'm here this time with your team members who will introduce themselves momentarily. And then we'll have a little review of all the information and events pertinent to your care. But first I have to ask you if you're okay with having this conversation in front of everybody here.
Well, yes, of course. I'm just anxious to find out what the plans are.
Good morning again, Mrs. Jones. As you know, I'm Trish, your nurse. We had a chance to talk earlier today.
Hello, Mrs. Jones. I'm Tawanda, the pharmacist. We
Hi,
met
Tawanda.
yesterday.
Yes.
Mrs. Jones, our goal today is to get you ready to transfer to rehab. But first, is there anything else you'd like to discuss with us this morning?
No, going to rehab is my main concern.
Okay. Well, if you have any concerns or questions that come to mind, just feel free to jot them down. Trish, could you please hand that pen and paper to Mrs. Jones?
Thank you.
Thank you very much. And yeah, we'll save time at the end so we can discuss any questions you have with you. First, we'll begin with a quick review of your hospitalization.
Mrs. Jones, I'm going to go over a short summary of your hospital stay with the team. Mrs. Jones, who is 75 years old, managing well at home, until 1 month ago she was admitted to the ICU with a stroke, presenting with left-sided weakness and difficulty swallowing. She was in the ICU with some ventilation issues and became septic from pneumonia. She was stabilized and transferred to us a week ago. A few days ago, she developed a DVT in her right leg and a heparin drip was started. The heparin was discontinued last night and she was converted to an oral agent. As we discussed, the plan was to start her on apixaban, but she got a dose of warfarin last night. Her vital signs have been stable. Her blood pressure has been within normal limits since making the changes to her blood pressure medicines yesterday. Her blood pressure was 120/78 this morning. Her pulse was 80 and regular, and she is afebrile. She has no central line, no Foley catheter, and her skin integrity is intact with no pressure injuries.
Thank you, Trish. Mrs. Jones, do you have any questions for us so far?
Not so far.
Okay, good. Well, I'd like to know how your appetite's been. Have you been eating more since you passed that swallow evaluation?
I think so.
Yes, I'm glad to see how well you're progressing and doing all of your exercises daily. She works with the speech and language therapist daily and has been doing all of her exercises. I see improvement each day. Her appetite is better and she's eating more calories with each meal.
Very good. What does the physical therapist say about Mrs. Jones' mobility?
The physical therapist states that Mrs. Jones can tolerate the required 3 hours of daily PT. Social work has arranged for her transfer to rehab setting here, and they have a bed now. They can take her if she's ready to be transferred.
Okay, I will review her medications for transfer.
So, how are you feeling, Mrs. Jones?
Actually, I'm feeling much better. I'm really looking forward to going home soon.
Yeah, I remember you're saying that your goal is to get on home and see that new granddaughter of yours. But, we'd like to get you a little bit stronger before we send you home.
Yes, I know. Trish told me that yesterday. I'm really nervous to think about what will happen to me. I'm still having trouble walking and eating. And I get very confused about taking the medication. I wonder how I'm going to manage all of this when I get home.
We'll review all of your medications with you before you go home and make sure you understand how to take them.
And the rehab team will be working with you to get you stronger.
I'm worried about this rehab. Someone told me that there are machines there that I'm expected to get on. Now, wouldn't that require that I be strong? Because I am feeling so weak. And that makes me wonder if rehab will even help someone in my condition.
Mrs. Jones, feeling anxious and fearful of the future is quite common in someone who's at this stage of recovery from a stroke. It's normal for a person to be fearful of the future and to feel scared about how you'll manage your affairs after leaving the hospital. And in fact, that's one reason why we recommend rehab after stroke. At the rehab center, you'll have a team of healthcare professionals who are experts in helping people like you at your stage of recovery, and they'll work with you and they'll help you regain your strength slowly through a series of activities and exercises.
You will have a physical therapist who will help you with walking, a speech therapist who will continue to work with you on your exercises to strengthen your swallowing, an occupational therapist who will help you with tips so you're able to do your everyday activities when you get back to your home.
Yeah, we'll make sure that the team at the rehab unit knows all about your medical problems and how you've progressed here at our unit to date.
Well, maybe I am a bit nervous about leaving here and taking the next step. There have been so many changes in my life lately. I've gotten to know all of you, and now I have to leave here and meet new people in a new place. Will my physical therapist be there?
You do sound a bit nervous about moving on to the next step in your recovery. The physical therapist you've been working with will not be at the rehab unit, but all of your notes and all your progress on your recovery will be included in the information that they have. One of the first things that'll happen is that you'll meet each member of the new team and they'll explain their roles. They'll work with you on your goals for recovery, like bathing and getting dressed. They'll help you with things like how your home is set up and how to prepare meals and take care of your home and things like that. We'll talk about rehab more later.
That sounds good. My husband will be here in a few hours.
Okay, well, Mrs. Jones, is there anything else you'd like to talk with us about today?
Well, my blood pressure, I know that it was low, but it's better now, isn't it?
Yes, your blood pressure is much better today. Your blood pressure this morning was 120 over 78, and your pulse is 80, which is perfectly normal.
Those vital signs are great. Sounds like stopping the amlodipine yesterday doing interprofessional rounds was a great idea by the team. For now, she appears to be controlled on lisinopril 20 milligrams a day and hydrochlorothiazide 25 milligrams daily.
Yes, it sounds like we found the medications to control your blood pressure for now. Your rehab team will follow up on your blood pressure issues, and so will your primary care physician later. We want it to be lower than it was when you came into the hospital, but not too low. And I'll ensure that the discharge medication list has the lisinopril and hydrochlorothiazide included on it.
I have a new blood pressure medicine?
Yes, we have all been working to get you on the right doses of your medications while you've been in the hospital. We will make sure you have an updated list, and I will go over each one, and we will talk about how to take them.
Oh, good, because I worry about making a mistake when I'm taking my medication.
Yes, I can see how that can happen, especially with everything you need to remember when you leave the hospital.
Well, what are those changes? I don't understand what all of you talked about, what I should be changing.
Okay, let's go over those, Mrs. Jones. It is common to have a few medication changes, starting new ones and sometimes stopping old ones when you leave the hospital. The first big change is the addition of the anticoagulant you are on.
Anticoagulant?
My apologies. Anticoagulant is a new term for you. It's a medical term of a medication that thins your blood a bit so that you don't develop a blood clot like you have in your leg now. A clot like that can travel to your lungs within your veins and can result in problems with breathing. We want to prevent that from happening again. This new medication called apixaban is very important and must be taken twice a day.
Is this the new medication they started me on last night? I can't remember the name of it, although I know the nurse told me. It's a little pink tablet.
You did receive an anticoagulant, but not the one you will be receiving once you leave here. Your insurance covers a newer medication, and we will switch to that medication, which will be easier for you to manage.
Okay, thanks for explaining that. Now, let me understand. I know that I had a stroke, but what about this blood clot? Why did I have a blood clot?
Sometimes that happens when you're immobilized or just not moving around as much, such as after you had the stroke.
Okay, that makes sense. Now, what are the changes that you're going to make with my other pills?
So in addition to the blood thinner apixaban, we also changed the medications that control your blood pressure. We added one that we think will work better in your situation after having a stroke, and we stopped the one that you were on before the stroke. I will come back a little later with a list of your medications and go over them all with you. Would you like for me to talk with you when your husband is here so that he can listen?
Oh, yes, that would be good. Thank you.
Okay, Mrs. Jones. I'll talk with you and your husband later. I'll bring some information about the new medications and why they are so important. Trish, if I'm not here when her husband comes, could you call me?
Sure thing, Tawanda. After Tawanda is finished, I'll review the discharge plan with you and answer any other questions you might have before your transfer. I'll write the goals and plan on the whiteboard for you as well.
Okay.
Okay, then it sounds like we have a plan. Mrs. Jones, to sum up our visit, we just reviewed your hospital course, the change in your medications for blood pressure and anticoagulation, and the plan for transfer to rehab. Do you have any questions we can answer before I do a physical exam?
No, nothing.
Okay, then. We'll check with Gary, the social worker, to confirm a time for your